Now we'll go to intravitreal injection. Last one, intravitreal injection and laser practice in wet lab setting. It's by Dr. Sapna Mohan, medical retina specialist, and she's working at Malabar Medical College, Calicut, in the Department of Ophthalmology. Dr. Sapna.
Thank you, sir. Good afternoon. Today I'll be discussing about how to practice retina in a wet lab. So, as sir have already mentioned, organizing a wet lab section can be an invaluable skill transfer section for the training PGs. Intravitreal injections can be performed in a wet lab using a GODS or bullseye under the supervision of a senior consultant, and it's a relatively inexpensive and effective method of training the students with a minimum cost-effective setup. So, what is intravitreal injection? It is basically a simple procedure of injecting a therapeutic agent into the vitreous cavity through the pars plana under strict aseptic precautions. So, if you follow the technique properly, it's a relatively simple procedure. So, what we did, this is a basic setup we did in our wet lab. We need an operating microscope. We need eyeballs. We need a supporting mold to support the eyeball along with a metal fixing ring. We needed a tuberculin syringe, that is a 1 ml syringe with a needle, and we needed a scleral marker to mark the site of injection. So, going quickly through the indications for intravitreal injections, we commonly use anti-VEGF drugs most commonly, followed by antibiotics and antifungals for endophthalmitis. We use antivirals for viral retinitis. We use antimetabolites in intraocular malignancies, steroid implants or steroid injections in the form of triamcinolone, and finally air and expansile gases in case of pneumatic retinopexy. So before teaching them the technique, it is more important to teach them why should we follow the correct technique. It is mainly to avoid these complications, that is the minor and major complications. So first complication in minor category is the injection site discomfort. Even though it may sound minor, it is one of the major cause for patient dropout during the treatment. So in the next slides we will discuss how to avoid it. Then we can have subconjunctival hemorrhage. We can have vitreous reflex. If while withdrawing the needle, if you do it quite quick or using a wide bore needle, it can result in vitreous reflex. There can be post-operative rise in intraocular pressure, and finally the patient may even complain of floaters in the immediate post-op day. That is mainly if you are injecting an air bubble along with the drug into the eyeball while drawing that is mainly a fault in preparation of the syringe for injection. Now coming to the major complications, we can have vitreous and retinal hemorrhages. We can have retinal detachment, even though it's quite rare. We can have lens subluxation if you are not careful about the site of injection. If you go slightly anterior, you can damage the ciliary zonules. And finally, the most devastating complication, endophthalmitis. So now going to the key points which we have to teach the students. Selection of the patient. In case of anti-VEGF agent, you should ask for a history of thromboembolic episodes like MI or cardiac issues and a stroke. If that is there in the past 6 months, you should avoid it. You should prefer steroid injections. And in case of steroid, you should think about the risk of cataract and glaucoma. And in case anti-VEGF injection, if you are planning a bevacizumab injection, you should get an informed consent because we are using it off-label. Now coming to dosage and preparation of the syringe for injection, we need separate needles to draw the drug from the vial and a separate needle for actual injection. So the commonly used volume of injection is somewhere between 0.05 ml and 0.1 ml. And if this is the volume we are using, then there is no need for routine anterior paracentesis. But if you are injecting more amount, like in case of a combination of antibiotics in endophthalmitis, we may need to do an anterior chamber paracentesis immediately following the injection. Coming to preparation, so like cataract surgery, we need strict aseptic precaution. After painting and draping the patient, we need to put in a lid speculum. That is mainly for better exposure and avoiding the contamination of the injection site. We should put paracaine drops at regular intervals. And one thing which I have noticed is dabbing the injection site with a paracaine soaked bud just before the injection produce much better comfort to the patient during the procedure. They hardly know the needle going in and out, and there is less chance for subconjunctival hemorrhage. So that is one thing which we all can practice. Just before the injection, we can dab the injection site with a paraffin soaked needle. Paraffin soaked bud. Coming to safe site injection, any clock hour is possible. Most common is infratemporal site, and we can mark the site from the limbal location using a scleral marker or a caliper. So the commonest distance is for a pseudophakic, we can do it at a distance of 3 to 3.5 millimeter away from the limbus. But in case of phakic patient, we can prefer a 4 millimeter distance from the limbus. And for children, accordingly, there is we can decrease the distance from the limbus according to the age. So technique is the most important. How to progress the needle to the eyeball. So first thing is needle gauge, selection of the needle. We can use both 26 gauge needle and 30 gauge needle, but I personally prefer the 30 gauge needle because it's small bore needle, so hardly any pain for the patient. They never even know the needle going in and out if you are using a 30 gauge. But in case of 26 gauge needle, they will tell you at what point exactly we have put the needle in. Then angle of needle insertion, ideally we prefer a 90-degree perpendicular to the site of injection. And depth of insertion, if it's a small bore needle, we can go all the way in. But if it's a 26 gauge needle, ideally 2/3 of the needle depth is preferable. Especially in patients with traction retinal detachment, it is ideally safer if you don't go all the way in. So coming to the post-injection, we can look for the optic nerve perfusion by any of these techniques. So these are the techniques we have to tell the trainees in the immediate post-op period, that is gross visual acuity, either visualization of optic nerve by indirect ophthalmoscope or IOP check by a non-contact tonometer. So this is a wet lab picture from the wet lab training section we did in MMC last April. This is intravitreal station. So retina laser. So this is the model we made for retina laser training of our PG. It is very cost effective using a transparent tumbler, carbon paper and twine. So this is one of our trainees practicing the laser on our model using slit lamp. So this second picture shows how the laser marks are falling on the carbon paper. So they get a feel of how to focus the laser, where to apply the laser, the gap between laser. So this is a video of them practicing it using an indirect ophthalmoscope. Thank you.
It was a very excellent demonstration of slides and explanation. Thank you, Dr. Sapna.